Alexander von Rosendael and Mike Gibson coming to you live from TCT 2024, and we are talking about the results of the CONFIRM-2 trial that you just presented. Obviously, many of us are familiar with the coronary artery calcium score or CAC score. I've had it done. I found that I had a very elevated one, which triggered me to get on some medicines. But you're moving beyond that, right, Alexander? You're really quantitating the amount of soft and hard plaque and the amount of total plaque and looking at outcomes. So personally, I was fascinated by what you had to say. Talk to us a little bit about the CONFIRM program and what you did in CONFIRM-2.
Yeah, thank you for the invitation to speak here. So, in symptomatic patients with suspected coronary artery disease, the main focus is usually on the detection of obstructive coronary artery disease, which may benefit from revascularization. But from the IVUS literature and also prior large CT cohorts, for instance, the CONFIRM-1, we know that the burden of atherosclerosis and especially the composition, they are much more predictive for future heart attacks than just the stenosis. So CT coronary angiography is especially suited for quantifying and assessing the total burden of atherosclerosis throughout the total coronary tree. So, and nowadays we have the ability to quantify atherosclerosis, which was not done before, like in CONFIRM-1, which is a large CT study. All the CT scans were assessed visually, but nowadays we can do it with we can do it with the help of artificial intelligence. We can quantify it, and that gives us reliable and reproducible measures of, for instance, total plaque volume or non-calcified plaque volume or high-risk plaques. And this quantifying has not been possible to do for like a few years ago, because it takes a lot of time to do it manually. But now with the help of AI, it only takes a few minutes. So that really brings us further into having quantified atherosclerosis into clinical practice. So there we go for the aim of the CONFIRM-1, sorry, for the CONFIRM-2. Our aim was to assess which of these quantitative CT features were most predictive for the future heart attacks in our primary endpoint. And also, is it more predictive than just like clinical risk factors or ASCVD risk score or Diamond-Forrester score?
Now, when you looked at all these factors, and you had a lot of them, some of them might collide with each other in a model. They're collinear. They're related to each other. So, for instance, a tighter blockage, a higher percent stenosis, might be correlated with greater plaque volume. So, how did you adjust for all these things that are very similar and competing with each other in a model?
Yeah, it's true. In our model, we entered 24 univariable CT predictors, and six of them were too collinear to be entered. And but the rest was possible statistically. There was enough difference between each other, and many of these still have different aspects of the disease that they target. And in the end, only two features were the most predictive for a primary endpoint, and that was the burden of non-calcified plaque, so not calcified but non-calcified plaque, together with stenosis severity. That were the most predictive features amongst all the univariable ones that we entered.
And I want to underscore, this is total plaque volume throughout the coronary tree. What's fascinating is we often do studies where we divide the tree into 9 areas: proximal, mid, distal for the right, the LAD, and the circ. Did you find that a segmented analysis, dividing the heart into 9 segments, was that any better than just using the total plaque volume?
Thanks for this question. The CONFIRM-2 took the plaques from every segment. So every segment was entered in the total plaque volume or the non-calcified plaque volume. This specific analysis you're referring to, we didn't perform, but that's something we will definitely do in the future.
Well, I asked that, Alexander, because as we're designing studies, this is always a big question of debate. Do we look at the 9 segments independently, or do we look at the total plaque volume? I'm more of a fan of total plaque volume. just because it's cleaner, and there can be collinearity in the behavior among the 9 different plaques, although I've shown they behave independently. So it's an important methodologic issue. I look forward to seeing what you have to say about it. So when you add in the risk factors like smoking, diabetes, all of those things, how does the model do when you add in traditional risk factors?
Yeah, thank you for this question. So what we saw was that just looking at the two features, the non-calcium plaque and the stenosis, it already gave a very strong risk stratification for primary endpoint. It had an area under the curve of 0.76. Actually, when you add on to that the Diamond-Forrester score and the risk factors, including smoking, hypertension, diabetes, and dyslipidemia, it did not increase the area under the curve significantly. When you entered all of these features together, the only 3 that remained significant were the non-calcium plaque burden, stenosis severity, and the diabetes. So, like reinforcing the fact that we need to look at the burden of non-calcium plaque and stenosis, and that brings much more prognostic information than the traditional risk factors.
So did adding in diabetes, did it up the AUC from that 0.76, 0.77, or was it still around 0.77?
It did not increase it significantly. No. So the CT model only was 0.76, and adding the clinical factors to it increased to 0.77 non-significantly.
So, Alexander, is this ready for prime time? I mean, should we be using this in clinical practice? What are the next steps?
Yeah, I think we are there or almost there to have this in clinical practice. So we need to focus on the non-calcified plaque burden, and that is by the eye is very, very difficult to do to assess the burden of non-calcified plaque, and that's where I think we really need the quantitative tools which we have now. And yeah, I think that's something we really need to focus on. We've seen before from IVUS and serial CT studies, we've seen that if you have a large burden of non-calcified plaque, first of all, you have a very high risk. But second, when you treat them with our most severe anti-atherosclerotic therapies, we can see that we transform the non-calcified plaque into calcium, which is a more stable type of plaque. And that really relates to fewer heart attacks in the future.
And you mentioned IVUS and OCT. Has this kind of measure been compared to them? I mean, in an individual patient, how do they compare with those measures? Are they highly correlated?
Yeah, there is a lot of comparison with intravascular ultrasound. The OCT is coming, but intravascular ultrasound is there already, and we see very, very highly correlated relationships between CT and IVUS for terms of plaque volume and non-calcified plaque volume. Yeah.
So I've had my calcium score, I've had a CT, angio. If I wanted to get this measurement done on mine, what would I do? I mean, how do I go about getting it measured?
Yeah, it's a software program, so it just needs to be run, and it gives you the numbers in a few minutes, and it gives you all these reproducible numbers like non-calcified plaque volume, and it gives it in cube millimeter or total plaque volume, highest stenosis degree, yeah, and much more. But these are the main ones we focus on right now. So yeah, it's a software program that you can apply to your conventional coronary CT scan.
Right.
You can
So I tell
comfort
my
people.
doctor to upload it to, is it Clearly is where this is done? Okay.
Yeah, yeah.
All right. Well, Alexander, great work. 3 years
Thank
of painful work there. Thank you. It's really helpful for people like me who have an elevated calcium score to understand this. Hopefully, it'll help guide the treatment decisions in a lot of patients. I know my treatment decisions were guided by getting that calcium score. So thanks for joining us, Alexander. And thanks to all of you for joining us here live from TCT 2024.